Everybody, and welcome back to another video here at Whiteboard Medicine. We appreciate you checking it out. Hope everybody is having a good day today. Today we're going to be covering another video within our Acute Respiratory Distress Syndrome ARDS series. And this is going to be an advanced video on diagnosis. Specifically, we're going to talk about what is now considered maybe the old diagnostic criteria being the Berlin criteria, as well as the brand new diagnostic criteria published by the American Journal of Respiratory and Critical Care Medicine, titled A New Global Definition of ARDS. We're going to talk about some background within ARDS, what these new diagnostic criteria are, how they differ from the previous Berlin criteria, some examples, and then what that might mean for all of us in the clinical arena. For those of you new to this channel, we're the channel Whiteboard Medicine. We are a medical education and medical news / public health YouTube channel. This is our home page here. We'd love for you to subscribe, join the community. If you're interested in ARDS in particular, if you go to playlists, we actually have a whole ARDS playlist that we've been putting together. At this point, we have a whole handful of lectures in there. It looks like around, we'll end up with 6, and we're going to kind of keep adding to this playlist. But this is all things ARDS if you want more info on ARDS. In addition to that, we do have a high-yield Patreon page. We'll link in this video's description where we post all sorts of kind of medical education, medical news, practice questions. We put all the video outlines on there as well as ad-free videos. So definitely consider joining that and hanging out with us on our Patreon community if you have an interest. No further ado, quick 30-second break for the introduction. Don't go anywhere. We'll be right back. Everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety.
All right, thanks for sticking around. So ARDS, Advanced Diagnosis. Well, this is a play off of a previous video we did on the ARDS basics, where we introduced what is kind of considered the more widespread diagnostic criteria known as the Berlin criteria. But since this time, something new has come out, but we thought we'd start with discussing the Berlin criteria just to get everybody on the same page, and we'll dive into this kind of new diagnostic approach. So the Berlin criteria originally were agreed upon back in 2012, so they've been around for quite a bit of time. And they're a set of 3 different criteria primarily. Criteria 1 is that there has to be new or, well, we should put a W there, worsening symptoms within 7 days of acute onset. I wonder if there was some kind of lag of acute onset of an event, okay? So we talked about ARDS in these previous videos, and definitely check those out, right? This is an advanced video, so we're not doing too much background discussion, which is why you should check out those other ones if this is all mysterious to you. But when we talked about ARDS, you need some kind of acute insult. Sometimes this is in the lung itself, like a pneumonia, right? Sometimes this is something outside of the lung, like pancreatitis. And there's a whole bunch of other examples, traumas, burns, pneumonitis, some chemotherapy, some drug-induced. So you need some new or worsening symptoms within 7 days of an acute event. All right, so this acute event would be something like a new pneumonia or sepsis or pancreatitis. And then you need new or worsening symptoms, these symptoms being respiratory symptoms, which we'll talk about. All right, within 7 days of this acute event, because this is not kind of a chronic progressive disease that happens over weeks or months. ARDS is an acute disease, so it has to follow an acute event, and it has to be within 7 days of that acute event, where you get those worsening respiratory symptoms, things like hypoxemia, hypercapnia, increased work of breathing. You also need bilateral opacities on imaging of the chest, right? Because ARDS is a diffuse lung disease. It affects both lungs. Now, there is some heterogeny, right? It does not affect all the lung areas of the lungs the same, but it does affect both lungs. So you need bilateral opacities on imaging of the chest. This is most commonly a chest x-ray. Sometimes it's a CT of the chest. And in the new diagnostic criteria, they actually had ultrasound, which we'll talk about. But this is a chest x-ray. This is a normal chest x-ray. So what you'd expect with ARDS is you'd have kind of bilateral patchy opacities diffusely that show up as, you know, that white fluffy color on both sides of the chest. You'd kind of have these bilateral opacities. And again, you can get that in a couple different ways, chest x-ray being the most common. And then the other thing in the Berlin criteria is you need to have a PaO2 to FiO2 ratio of less than 300 on more than 5 of PEEP. And this is going to change, right? Because PEEP implies you're on non-invasive ventilation or mechanical ventilation, BiPAP, CPAP, or a ventilator. So it does include things like nasal cannula or high flow, but the new criteria do. But you need a P to F ratio of less than 300. And this is where you get an arterial blood gas and ABG, right? Sampling of the arterial blood. You look at the PaO2, the partial pressure of dissolved arterial oxygen. And then you divide that by the FiO2, the fraction of inspired oxygen. So let's say they're on an FiO2 of 100% on the ventilator. You get an ABG and their PaO2 on that is 100. You would divide 100, right, by the FiO2 of 100%, which when we make it not to 8% would just be 1, right? And that P to F ratio would be 100. That's less than 300, so that'd be consistent with ARDS. Okay. The caveat to this is these have to be not secondary to cardiogenic pathology. So this all can't just be pulmonary edema, cardiogenic pulmonary edema. You have to rule that out because that can't be the sole cause of these symptoms within the Berlin criteria. All right, and these are kind of the 3 general diagnostic criteria within the Berlin criteria. Okay, you need new or worsening respiratory symptoms within 7 days of an acute event. Okay, you need bilateral opacities on imaging of the chest that are not explained by pulmonary edema from the heart alone. You need a P to F ratio of less than 300 millimeters of mercury on more than 5 of PEEP. But 2024, lots of experts all came together and came up with what they're calling the new Global Definition of Acute ARDS, because they felt like the Berlin criteria were getting a little outdated. They're from 2012. They wanted to all come together and rediscuss these things. We'll link this article in the video description. This is the citation. The tables and figures and things we're using are from their article, so certainly want to give credit where credit is due. That's the citation. Again, it'll be linked in this video's description. And they talk about a lot of things in this article, and we took a few snapshots of different things from the article. We wanted to start, though, with just this little blurb, right, about ARDS. And again, this is something we've covered in other videos related to ARDS, so we're not going to dive into it as much here. But ARDS is an acute diffuse inflammatory lung injury, right? So it's acute in nature, right? Berlin criteria said that's less than 7 days. It's diffuse, affects both lungs. Inflammation precipitated by some predisposing risk factor. We mentioned it could be pneumonia, it could be a predisposing factor from the lungs, right? It could be a non-pulmonary infection, intra-abdominal sepsis, urine sepsis. It could be from trauma, it could be from transfusion of blood products, burn, aspiration, shock. All these, both pulmonary and non-pulmonary things, can cause ARDS. But ARDS needs a nidus. It needs a predisposing factor that precipitates it. All right. This resulting injury leads to increased pulmonary, vascular, and epithelial permeability, lung edema, and gravity-dependent atelectasis. And this is kind of the pathophysiology. And if this is the playlist for our ARDS videos, we dive into it deeply in this ARDS Advanced Pathophysiology video. So definitely check that out if you want a deeper dive on the pathophys. But all these things contribute to loss of aerated lung tissue. So loss of areas of the lung that can exchange gas. All right, and as such, the clinical hallmarks of ARDS are arterial hypoxemia, low oxygen levels in the arterial blood, right? Because that lung tissue is so diseased, it can't exchange gas, right? It can't get oxygen from the atmosphere into the blood vessels through the walls of those diseased alveoli. And diffuse radiographic opacities associated with increased shunting, increased alveolar dead space, and decreased lung compliance. Again, all things we talked about in the pathophysiology lecture. But this is essentially saying that the diseased lung, because it cannot exchange oxygen, you get shunting, so you get blood flow to areas of lung that is diseased and thus can't get carbon dioxide out of those blood vessels, can't get oxygen in, so that blood shunts by those diseased air spaces. All right, you get increased alveolar dead space, which means you're breathing air into parts of the lung that are not exchanging gas. And then decreased lung compliance, that lung starts to get stiff because it gets so diseased. All right, the clinical presentation is influenced by medical management, position, sedation, paralysis, PEEP, fluid balance. Again, not to beat the same drum over and over, but in our ARDS, we have this advanced management video, and this is where we talk about all the advanced management strategies for ARDS, so check that out too. And then histological features have intraalveolar edema, inflammation, hyaline membranes, alveolar hemorrhage. So this was just a really quick summary on what ARDS is, the pathophys behind it, what can cause it, and then the different management techniques. But again, check out those other videos for deep dives on all these things so that you could be a master of ARDS. Let's get into the diagnostic criteria. These are the new global diagnostic criteria for ARDS. All right, and you might note that there's some kind of overlap that we're seeing, right? Well, first off, there's these three diagnostic criteria, and they look somewhat familiar, right? Risk factors and origin of edema. If we go up to the Berlin criteria, right? Risk factors, aka acute event or something that causes it. So they're saying it has to be precipitated by acute predisposing risk factor. Like they said above, it could be pneumonia, it could be non-pulmonary infection like trauma, transfusion, aspiration, shock. Pulmonary edema, this is important, we're going to highlight this portion. Pulmonary edema is not exclusively or primarily attributable to cardiogenic pulmonary edema or fluid overload. And hypoxemia gas exchange abnormalities are not primarily attributable to atelectasis or pleural effusion or pulmonary embolism. So this is going and saying, even as the Berlin criteria had, that there has to be an acute event causing ARDS, right? There has to be that acute event. And in addition to that, there has to be those bilateral infiltrates. There has to be disease of the lungs, but it cannot be caused by cardiogenic pulmonary edema. It can't just be fluid overload. All right, so it has to be non-cardiogenic. And they go a little further and say, yeah, it also can't be from atelectasis, which is just some lung collapse. It can't be from a pulmonary embolism. It can't be from pleural effusion, right? Because all those things wouldn't be ARDS. ARDS is inflammation and damage of the lung tissue itself. And as such, these other things would not be consistent with ARDS. So you can't have all this hypoxemia, all this low oxygen just from a big pulmonary embolism or just from big pleural effusions or from pulmonary edema from fluid overload because you're in heart failure, okay? In addition to that, they go on to say that ARDS can be diagnosed in the presence of these conditions if a predisposing risk factor for ARDS is also present. So they kind of are a little softer in their language here and they say, okay, well, you can have cardiogenic pulmonary edema, you can have pleural effusions, but it can't just be that, right? There has to be something else as well, and all that hypoxemia can't be solely attributable to the pulmonary embolism or the pleural effusions or the heart failure exacerbation. All right. Next, they talk about timing, right? If we go up, we talked about timing. And here as well, they said within 7 days. The new criteria say acute onset of worsening hypoxemic respiratory within 1 week, so still 7 days, of estimated onset of the predisposing risk factor, or new or worsening respiratory symptoms. So this is a little bit new, right? So they're saying, yeah, it has to be within 7 days of new or worsening respiratory symptoms, but the worsenings allows us to have a little more kind of grace. This can be a little further than 7 days as long as things have kind of been progressively worsening. All right, so they maintain the 7 days, but they're a little softer on their language to allow for a little more grace that it could be beyond that. And then chest imaging, you have to have bilateral opacities on chest radiography, NCT scan, or bilateral B lines on ultrasound. So the ultrasound was the new addition here. So you still have to have bilateral infiltrates, but you can use ultrasound, especially if you're in a place that doesn't have other modalities of chest imaging to help diagnose this. So you can see these are about the same as the Berlin criteria if we go back up, right? New or worsening symptoms within 7 days of acute event, right? The new criteria give a little more grace to the 7-day number. You have to have bilateral opacities on imaging of the chest. The new criteria added ultrasound to the potential for this imaging. And then you have to have a P to F of less than 300. Well, we actually haven't gotten to this in the new criteria yet because this is where things also get a little bit different. But then they did say that all these can't be secondary solely to cardiogenic pathology or atelectasis or pleural effusion or pulmonary embolism. Although these things can be involved, they just cannot be the sole cause, right? Cannot be sole cause of the hypoxemia. All right, so then these new diagnostic criteria, instead of just giving one generic statement like this, break this down into a couple different things. They say, okay, well now the management of ARDS has evolved a little bit. Not every patient is intubated. Not every patient's on a ventilator. Some patients are just on high flow. And then there's resource limited settings where the approach might be totally different. So they broke it down into these three things. And they said, okay, if you have risk factors and an origin of edema that makes sense, timing that makes sense, and chest imaging that makes sense, well then we're going to say now go down here and categorize your patient. If your patient is not intubated, then their oxygenation, they have to have a P to F ratio of less than 300. Right? This is the same as Berlin, less than 300. Or if you're not going to get an ABG, right, because to get a PaO2, you need an ABG. So they said if you're not going to do that, you can use the SpO2. This is just the oxygen saturation on the monitor itself. And your SpO2 to FiO2 ratio has to be less than 315, okay? And the SpO2 has to be less than 97%, right? They can't just be setting 100% on SpO2. And since these are non-intubated patients, they say that this can be on heated high flow, but the heated high flow has to be at least 30 liters per minute, or you could be on non-invasive ventilation with at least a PEEP of 5. So if we go up, the Berlin criteria had this PEEP of 5 involved. You had to be on a PEEP of 5, which didn't leave for people on high-flow nasal cannula. But now the new criteria say, oh, no, we include high-flow nasal cannula. We know that that is being used more often, but you have to be on at least a liter flow of 30 liters per minute of high-flow nasal cannula. All right, so similar to the old criteria, but just adding a couple things in. Adding in a high-flow nasal oxygenation option, right? Adding in an SpO2 to FiO2 ratio option were new additions. If you're intubated, it's about the same, right? There's mild ARDS, there's moderate, and there's severe, right? Mild is that P to F ratio of less than 300, but above 200. Okay, moderate is above 100 but less than 200, and severe is less than 100. These are all the same as they have been, but then they do add in these SpO2 options where you can gauge mild, moderate, or severe based on just the oxygen saturation on the monitor rather than having to get an arterial blood gas. But again, that SpO2 has to be less than 97% to do it. Okie doke, and then there's a modified definition for resource limited settings, and you could read through more of this as your interest drives, but if they're not on positive end expiratory pressure or minimum flow rate of oxygen, there's still an ability to diagnose ARDS. So where do the authors feel like they went mostly different than the Berlin criteria? Right, this summary of key differences between new global definition and Berlin definition. So Berlin definition, rationale for updating criteria, and how this affects the global definition. Well, they say that the acute onset within 1 week of known insult or new or worsening respiratory symptoms they address, because they said that the onset may be more indolent, it may be slower for some insults, and we saw this particularly with COVID-19. All right, so they included heated high flow to capture patients with these more indolent courses, patients who kind of progressed more slowly and were on high flow so that you could still diagnose them with ARDS while they were on high flow before they needed something like intubation or BiPAP. Okay. Another part of the Berlin definition was bilateral opacities on chest radiography or CT scan, not fully explained by pleural effusions, atelectasis, nodules, or cardiogenic pulmonary edema. And they essentially said that they're acknowledging that chest x-ray and CT scan isn't always readily available, so they added ultrasound as a diagnostic modality to identify these bilateral infiltrates. They talked about the 3 severity categories defined by P to F ratios, right? We talked about how there was mild, there was moderate, and there's severe P to F ratios, right? This was less than 100, moderate was 100 to 200, and mild was 200 to 300. You probably can't read that, that's okay. But what they said is that they added pulse oximetry measures, SpO2 oxygen saturations, because this is widely used and has been validated as a surrogate for the PaO2. Because remember, to get a PaO2 measurement, you need an arterial blood gas. But the SpO2 is just on the monitor. So they said you can start using SpO2 to FiO2 ratios. Although the numbers are different, right? Don't forget that. In here, the SpO2 to FiO2 ratios have always been slightly different than the P to F ratios in these measurements, but you can use SpO2 to FiO2 ratios. All right, and then last was requirements for invasive or non-invasive mechanical ventilation. And in the original Berlin criteria, there's this PEEP greater than 5, which was required for all categories of ARDS. So this meant that high flow nasal oxygen was not part of the diagnostic criteria, but they said, we're using it a lot now. It's increasingly being used in patients with severe hypoxemia and ARDS. So they just updated updated it to allow for the diagnosis of ARDS while on high flow, as long as you're on more than 30 liters per minute of high flow. And you obviously meet all the other criteria. All right, so they provided a couple examples just to kind of take things home for patients who meet the new definition of ARDS. The first is this gentleman, 68-year-old male, abdominal sepsis, septic shock, and acute hypoxemic respiratory failure. Here's their chest x-ray. They have these bilateral fluffy infiltrates. They were intubated and placed on mechanical ventilation with an FiO2 of 0.5, a PaO2 of 75, and they cheated here. They gave you the P-to-F ratio of 150, right? Because that's going to be 75 divided by the FiO2 of 0.5 equals 150. Does this meet the formal definition of ARDS? Well, what do we have? We have an acute event, an acute insult, abdominal sepsis, and septic shock. All right. We have symptoms that develop presumably within 7 days. We have bilateral infiltrates seen on chest x-ray that are not cardiogenic in origin. And then we have a P-to-F ratio of less than 300. This is intubated ARDS. Severity is moderate ARDS, right? Because that P-to-F ratio is between 100 and 200, which is consistent with moderate. And this is a typical patient that would be well included in the Berlin criteria. So then they move on to the second example. And you can see that this patient is not intubated. So by the previous Berlin criteria, you couldn't document this diagnose this patient with ARDS. Now, I think a lot of us did, but strictly speaking, by the previous Berlin criteria, you were unable to. But by the new criteria, can we? 54-year-old female, history of breast cancer with COVID pneumonia, worsening shortness of breath over the past 6 days. They're giving us some hints here. Here's a chest x-ray. See all these white fluffy infiltrates on both sides? Right? Bilateral patchy infiltrates. They're on high flow nasal oxygen with a liter flow rate of 30 liters per minute, FiO2 of 8.8, SpO2 of 91%. Is this consistent with ARDS by the new global definition? Well, what do we have? We have an acute event, COVID pneumonia. It's within 7 days, right? It's within 6 days, for the past 6 days. They have chest imaging with bilateral infiltrates that are not explained by cardiogenic pulmonary edema. And they're on high-flow nasal cannula, right? Before we were not able to use high-flow nasal cannula to diagnose ARDS. But now you can. But they have to be on more than 30 liters per minute of flow. Is this patient? Yep, they're on 40 liters per minute. So we say, okay, we can use this. So what is our P-to-F ratio? And they go, well, we're not going to give you an arterial blood gas. But we do have an SpO2. In the new criteria, you can use the SpO2 to FiO2 ratio. And the S-to-F ratio here, 114, right? 91 divided by 0.8 equals 114. And by the new global definition, this fits the non-intubated ARDS, right? If we go up here, non-intubated ARDS, and I'll erase all of my scribbles just so you can see it better, right? This fits. The patient is on high flow at greater than 30 liters per minute, all right? Their SpO2 to FiO2 ratio is less than 315. And if you were to give it a severity, you would run into the issue where severities are only mostly present for intubated ARDS, right? So it's hard to do severities for non-intubated ARDS. It's not part of the diagnostic criteria. But what you can say is the patient does fit criteria for ARDS based on the new global definition. And this is the resource limited example, 39-year-old female abdominal sepsis. So that's an acute event. Gram-negative bacteremia, that's an acute event. Under-resourced hospital without blood gas lab, without radiography, and without mechanical ventilation. So they do a bedside ultrasound. You see all these shimmering lines going down here? Those are called B lines, right? B lines have to shimmer more than 12 centimeters. And this person was put on an oxygen face mask. So they do have bilateral infiltrates based on bedside ultrasound with B lines. They have an SpO2 to FiO2 ratio of 142, right? That's the 85 divided by 0.6. And this does qualify as severe ARDS per the new global definition. All right, so that was lots of information. Some of the, highlights would be that a lot of the diagnostic criteria are very similar to the Berlin criteria. So going by that is still not unreasonable. The things to note, though, would be that high flow example, where you now can diagnose ARDS with heated high flow, although you can't divide it into mild, moderate, or severe ARDS when they're on high flow. And then the other thing would be using the SpO2, right? The oxygen saturation on the monitor, as long as it's less than 97%, the SpO2 to FiO2 ratio, which does not require an arterial blood gas. Now, that's not going to be perfect every time. There's lots of limitations to using the SpO2, right? They have done studies a ton. Critical illness makes the SpO2 less dependable. Darker skin complexions makes the SpO2 less dependable. Sorry, we're just going to finish writing that out. So there's a lot of things that can make SpO2 less dependable, which is why arterial blood gas is still something that I think we'll use in our clinical practice. But if the arterial blood gas and the oxygen saturation SpO2 are lining up and correlating, maybe that's rationale then to just go forward with the SpO2 thereafter. Hope that was interesting, helpful, educational. Let us know what thoughts, comments, questions you have down below. Check out the ARDS playlist. Check out our Patreon page. We'll have some practice questions on this lecture, as well as the video outline and the ad-free video. We appreciate you all. Stay well, keep learning. We'll see you next time.